Let's try it. Okay. You can use that. There's no extension.
Free. One.
That was one. Use it.
They are saying that it's something that was discussed. Well, if you have, can you give one of the
If I stop the slideshow.
Because yesterday it was very dim.
Sharing my screen. You can do it. It's now.
Thank you. I think you have adjusted a bit.
Right now, is what I just said.
That's okay now. It's okay now.
Yes, indeed.
But it's still a bit adjusted. It's still a bit adjusted. Just the price of the yesterday.
Even what the
It's okay now. But still the this one.
it's okay now. I think it was
Good morning. Good morning. You're most welcome to our second day. I'm calling us to order. Wherever you are, bring yourself back into the room. Hopefully you had a good night in Moroto. Yes, those that travel from other regions, it's a cold Moroto. Hopefully that weather was very comfortable. I know it was comfortable for Milton. Yeah. You found the cold Moroto, not the hot one. And hopefully it was also good for Dr. Mwanguzi. Yes, the team from Kampala and Dr. Chiema. Hopefully it was a good night in Karamoja. Yes, thank you so much. Welcome back from yesterday. I think smiley photos of how glamorous yesterday was. The launch was quite depictive of great things that happened. And we're happy that we had the success of the launch of the Karamoja Public Health Emergency Operations Center. Creates great significance in of understanding the essence of public health response. Images continue going on and saying exactly what happened. Yeah, so we can. We had some good feedbacks, definitely, of what happened. Thank you so much. Positive feedback, definitely. The arrangement as organized. This is our third review mission, and so we always expect ourselves to be better and better at what we do as Karamoja region. So we have the optimism that things will only get better and better. It only gets better, it never gets worse. And we have also experienced some good things like partner collaboration at its best so far, where we still need to recognize, we need to appreciate the partners that have made this event very successful. It's a very expensive event. It's such a time where there is dwindling funding. We are without duplication. And today I still expect participants to be within the house. We had some good introductions yesterday, and I'm also happy. I already have our spiritual leader in the house. Definitely, I will invite him back to usher us into day 2. I feel when the energy may forget God, and that's why they call us to order. Let us get already. Coming, you're welcome. Please come and give us a look. Good morning. Good morning. And praise the Lord. Amen. Welcome to our second day. Let me just draw your attention to a scripture. Psalms Psalm 1 this morning. I'll read from NIV version. Blessed is the man who does not walk in the counsel of the wicked, or stand in the way of sinners, or sit in the seat of mockers. His delight is in the law of the Lord, and on his law he meditates day and night. He is like a tree planted by streams of water, which yield its fruit in season, and whose leaf does not wither, whatever he does prospers. Not so the wicked. They are like chaff that the wind blows away. Therefore the wicked will not stand in the judgment, nor sinners in the assembly of the righteous. For the Lord knows the way of the righteous, but the way of the ungodly shall perish. This morning, I would like to inspire us to always look forward to being the kind of people who know their God, who read and meditate on scripture, because you cannot do without this. Then we will be like trees planted by the riverside that will bear fruit through the seasons. And it is our pleasure to end well, that as we live in this world, as the time draws close, we will exit and end. So my encouragement to us this morning is to be like this tree, and we are all like this. Let's pray. Father, the King of Kings, the Creator of the universe, you have given us life so that we will benefit the kingdom of God and humanity on earth. And you made us professionals who stand in very key positions in this world, in this part of the country, so that your people see the goodness of God. And you have given us partners, donors, supporters, people who will enable us to do exactly the things you want us to do. We are your children. We come and ask you to strengthen us, especially our position for us and you, that we will be those who are like trees that are not moved. Even in hard times, we remain fruitful, meditating on your word day and night. But I pray in the name of Jesus this morning as we begin this day, that we will meditate on this word and know that every single day we ought to be bearing fruit for your glory. And I pray for strength this day. I pray for new insights. I pray for the inspiration of the Holy Spirit upon us, that all that we discussing will be clear in our minds, and will perceive all that you want us to perceive very clearly, so that as we get into the new year, we will be doing the things you want us to do to help your people and to bring glory to your name. Give us strength and good health, peace and protection, and the love to bestow upon your people, and the joy to do your work, knowing that what we are doing is for your glory. In Jesus' name we pray. Amen. thank you, our spiritual leader, and for the inspirations we had this morning. Morning time is very good for reflection. And seeing how we can seek so to help us with developing very good conscience towards many things that we do. Thank you so much for the inspiration from the book of Psalms, and hopefully you've taken something good out of it. Ladies and gentlemen, you're most welcome to coming. You're most welcome for day 2 of our joint review mission. And we expect ourselves to run through this program. There's a lot of packaging. I know yesterday we had quite a very busy program that rushed us through quite a lot of things. But however, today we went to a lot of discussions as well in terms of performance, how we came to see the pictures of what, but significantly we can take note of key public health issues that we are addressing in Karamoja region. And we take note that Karamoja is a region that is prone to epidemics. There are very many factors. We're a nomadic kind of population, so, and also heavily migratory. And we see ourselves also having bordered by over 3 countries: South Sudan, Ethiopia, Kenya, all around this northern horn. So the borders are very porous, so it means in case there is a weakness in one health system, it still keeps us. Sentinel cases came from Kenya, the Turkana region, and then we saw that quite the numbers coming into Karamoja. So some of those are key dynamics that make us look at public health as a very strong aspect of health investment. And we also want to drive us to the agenda that is majorly, we want to so much shift away from the curative and look at seeing how do we address most of these diseases before they become diseases, basically. How do we avert infections, new infections? How do we stop, control the number of people who are developing these non-communicable diseases? And also, how do we address some of these other issues that are becoming public health concerns, like the road traffic accidents? And we have the security team is here, the RPC, the teams that are addressing issues of road traffic. Many people are dying, and we are receiving them in the hospital. They're overwhelming the hospital. And so if we do not have the public health arm very strong, it means we will have a very heavy cost bearing in terms of the overwhelming the hospitals. Now, you see, every accident means you're going to invest in a lot of money per accident that we have. The one vehicle falling off, it means about 3 or 4 or more 10s or 20s of people must come to the hospital, and they must overwhelm the same resources, limited resources that we're having. So in one or the other, every person has a way of handling some of these. We see Karamoja yesterday, according to regional performance, we took note of malaria being can be prevented from the community level. And now we get to know that the cultural leaders, like in Karamoja, get note that we respect the voices of the elders a lot. In most of our health scripts as partners, what we write is get to the Panyata leaders, the cultural leaders, and that's why we see that you're very handy in some of these things. 90% of the engagements of the population is at community level, so they only come to the hospitals within maybe a range of 10 to even less than 1%. So we see that community interventions, community ownership of these health programs is very important. So it's part of the things that we will interest ourselves in our discussions today, is that what can we do as infections? In elsewhere, we see that infections are going down. Now we are giving these mosquito nets, and we are doing this seasonal malaria chemo prophylaxis. Malaria consortium has been so handy in some of these things. We are educating our mothers, but the issue is how is the the structures, community development officers, the health educators, what are we doing about averting some of these problems? We took note of some of the key issues, like our mothers who are dying. And we took note that 48% of our mothers who are dying out of bleeding and maternal bleeding. But also we took note that majority of the people who are dying are age 15 to 19. Now I want to interest most of you here to a bit tired by evening when Vicky was running through some of these things. But these are things I want to interest us into. That majority of our mothers who are dying of this bleeding, 15 to 19. And basically that is teenage, the teenage age. And we also took note that Amodas per se has the highest proportion of teenage pregnancy. And so as leaders, cultural leaders, political leaders, DHOs, different stakeholders, what are we doing about the culture? What are we doing about this? Second, we took note of ABIM. ABIM, I think, was second in terms of teenage pregnancy. So, and you see that the health workers in the region or in this house may not have the biggest answers to some of these questions. So, but you are stakeholders, the elders, the religious leaders, the politicians, the LC5s, you have a big say in driving some of these things. Policies at district level. How do we handle teenage pregnancy? How do we come up with policies that keep our girls in school? And so some of those things we are looking at. The census still shows that majority of more than 70% of our people are basically young people, and we need to make them productive, but they also have to be healthy. They shouldn't be dying at the same time. So some of those key things I want to trust us into our discussions. We take note that as these young children, these young girls are dying, we know that some of these pregnancies are preventable. But we are seeing that we saw the utilization of family planning only at 8% in Karamoja region. Some of the surveys showed that Karamoja is the most fertile in terms of fertility rates. Karamoja is the most fertile region. Fertility rate at 6.7. And so every household per se in Karamoja must be giving birth to an estimate of every woman should be giving birth to at least seven children. And so and some of those are key issues of concern. That how do we embrace family planning per se to have some of this? You may tell us the population is low, but let me tell you also the rising. The challenge is let the population rise with quality, not with quantity. Because the challenge is you're giving birth to very many, but also the very many people are dying. So you see that we are giving birth to many children, but also the children are not surviving. And why? Because most of the mothers who are giving birth are not ready to give birth yet. So they themselves are dying, but at the same time, also the children we give birth to are also dying. And most of them are also not going to school. So some of those are key contextual issues that we want to trust us. They were part of the key slides that we discussed yesterday. And I know there are quite a number of answers. So in our today's discussion, it will be 8 more that we'll be discussing. We get to realize staffing is an issue. What are we doing about human resource gaps that we talked about? And all those things are tantamount to a sense that public health is very core. And what we're also moving to is multi-sectorial approach. So that's why we see One Health is very important. Is that many diseases right now as a country we are dealing with mpox. Mpox is a disease coming from monkeys, I think. So that's we call it monkeypox. So you find yourself is that One Health is very important. That's why as a region, Karamoja, we have very many animals, and one of the things you see that we have the national park in Nebo, we have the Matanico Forest Reserve, we have the Okora, we have so definitely we have quite a number of animals around. So One Health is very significant for us. How do we integrate ourselves, the veterinary team? And you know, in this region we eat a lot of wild animals. Then wild animals, how we I've seen some key captions of someone how they kill a rat and how they roast it nicely. There was one post of a very nice Karamoja dialect that was showing us how the guy the rat. And some of those interest ourselves into One Health, that how do we educate our people? We have to continue eating the things. How do we remain healthy amidst eating wild meat? So members, this is just to interest us into today. I want in a few minutes, those are just a few recaps. Some of them you're seeing as images coming through of how we managed to launch that. And we are so optimistic that I also want to interest us that get yourself interested in surveillance. We will be sharing with us every week we have the bulletin, and that utilize it well. We also want to devise the way of making it more fun to some of us who don't want to read very many big tables and the greens and rates, to just have 6 selected things on a weekly basis, such that all of us stakeholders in the house are able to have these weekly bulletins coming to us and be able to understand what is happening in Abadan, what is happening in Kotido, and what is happening within Karamoja region. So the media team and then the other different stakeholders will be handling in terms of health response. So, ladies and gentlemen, having given us a feel of just what happened here, spent in terms of time. I know performance. We have a section of health performance, and then we will be discussing that. But before I entrust us into that, I don't know whether our Ministry of Health team at the SCAP department has. I want to give you. Are you ready, Doctor? Okay. Have you shared the mark? Have you shared with the IT? Let us have your presentations with the IT so that we do not spend our time here. Today we want to rush the program quite fast, but we may end this. We also have a session to discuss One Health in a short time. I know the experts are in the house. We have Dr. David Mwanzi in charge of One Health, and you know, he also is of the veterinary department. And so we are here integrating things, and he will justify quite a lot of things in time. We will also have a session, a small part of basically to talk about a few things. The DHO after that has been contacted, and then I think we also have the One Health expert. We really interest ourselves into having one RDC, you know, RDC is run task forces, and then I think one partner in charge of One Health. I think UHA is so into that. We also have Dr. Andrew Gerald. We will listen from your experience on the partner side. So a brief panel discussion on the experience of One Health is today will be handy this morning. And so that's why we have this session, just a small panel discussion. We will be looking at what is working, what is not working, and what can be recommended. Those are just key questions. And I know your expert decision, your expert input to this house will give us the output. Then we'll take a discussion, and so we will then the one together with the 8 memo will come in together Then we're also looking at partners to also entrust us in key presentations of what is happening. In a summary, what are the key asks that we have from the partners today? And I think we will have the resolutions in the afternoon, and then we should be looking towards closure very fast. That's how we will run through the day. And so, okay, good. So let us have the Moroto regional referral. Please run through us. This is a continuation of yesterday's performance. So the regional referral will give us a regional perspective before we, I think, have the Ministry of Health team coming. So please, Mark, give us a short time here, and let us pay attention.
Morning, everyone. I'm going to be presenting on behalf of the hospital director, Moroto Regional Referral Hospital. And what you see is our annual performance review presentation in relation to the regional mandate. But specifically, the focus is on the specialized services that Moroto Regional Referral Hospital offers in the region. And in our overview, the outlay is as follows. Next. So basically, that picture shows the completion of maternity wards. Next. So in our vision, we have a center of excellence for health quality services, medical training and research. And in our mission statement, we are to provide quality preventive, promotive, rehabilitative, specialized curative services, medical training and research in the Karamoja sub-region. Next. So those are some of our mandates as a regional referral hospital. Next. Now, in relation to our outpatient and inpatient performance, you would observe that there's an improved OPD attendance by 11%. And so the adult and children's clinic, there was a spark of a 23% attendance looking at the two financial years of 22-23 and 23-24. We can see that the hospital referral scheme from other facilities have increased by 10%. And so we also refer patients to other facilities, and we can see that our referrals out as a hospital to other specialized national referral hospitals, it has reduced by 11%. And thus, there has been observed hospital admissions increase of 31%. So when you look at specialized services, like I said earlier, that basically highlight areas of health service provision, and in this case, if you see some of our units of their attendances have and so that increase percent, and basically we have seen that there is over 2,000 and so hepatitis clinic also, it is attendances has doubled than in the previous financial years, and hepatitis B in the in the hospital. Basically, we looked at the leading causes of OPD visits, and what you see is basically a rank of the illnesses that attracted OPD patients. And you can see that the cold pneumonia is now the leading cause of sickness among our patients, with a 40% burden. And malaria infection has reduced. And just for your that for Moroto district and where the regional referral hospital is seated, malaria burden has significantly reduced. And this reduction is a 9% of yes, the regional performance presentation. You observe that the malaria is still the leading cause of illness, but however, for Moroto district, the picture is different. And so we also see that road traffic accidents is contributing to population well-being, and we see reproductive conditions being among top 4 causes of morbidity, of sickness among our attendances as a hospital. Next. So here basically we looked at our admissions, and we can see that pediatric ward has a high number of admissions, and so we can see generally that there is an increase in admissions by 31%, as I highlighted in the previous slides. There is also an increased admission in neonatal child units by 3.3%. And so we are seeing that the referrals at neonatal units in action, but for pediatric admission, of course, I've already talked about it, which has increased by 7 points. So that should be triggering us to we can put in place to make sure that we attend to these children at low facilities, so that by the time they come to the regional referral, we should basically work critically ill, not as we see them. So in relation to the causes of admissions, basically we can see malaria remains, though in illness we can see that it's not, and pneumonia leading to under 5 admissions, and so cataract surgery leading to a cause of adult admissions in eye clinic, and that basically points out the issues of neglected tropical diseases, because the community, our community hygiene could be leading us to cases of that. The other one is that there is increasing gynecological conditions among hospital admissions. The next slide, please. So here we looked at the trends of the leading causes of mortality or deaths among the admitted patients from financial year 2020, 21 to the last financial year. And so you can see among the top causes of deaths, you can see that in the first columns here, you will see that pneumonia and malaria, and then premature deaths. But in the last columns on my right, you basically have to look at what would be the main causes of premature deaths. I think that's the most important, so that we, in the plenary and in our discussions, we should be able to look at basically how can we avert these premature births. And so, because we see that it's the leading causes of, the first top 3 you can see it's just about their neonatal and infant deaths. So we could be having in a discussion how basically the strategies we can employ as districts to avert this kind of deaths. Next. So here, basically we looked at laboratory services, and you can see that there's improved laboratory visits in the last 2 financial years with culture sensitivity and soil microscopy that were being requested and performed by the laboratory team. And culture sensitivity is basically where they test for the bacteria and the germs in the blood. And so we can see that, of course, one to appreciate is that Moroto Regional Referral Hospital is accredited by SANA. That is an laboratory accreditation firm in South Africa. And so we are, and so we can see that our rates among microbiologists in both financial years. If you can look at row 5, you can see that number of cases that are visited, row 5. Row 5, I think 6, yes, microbiology. Yes, if you can see the number of tests that are requested versus the positivities, you can see that that is half in both financial years. So basically, that points out that the burden of disease in the community among our OPD attendances is still high. So what we also observed in this 2 financial years is that the immunology test, that is where we test for CD4, TB LAM for those who are HIV positives, basically, including hepatitis in our last bulletin in the lower section, has decreased by 6%. In the next slide, please. So when basically here, we wanted to look at radiology services in the hospital, and basically we know that Moroto Regional Referral Hospital has a CT scan machine, and you can see that based on that, our computed tomography scanning services has increased by 74%, thanks to the MOH on due to delayed servicing, and also the issues of films for the X-ray films. Next, here basically I wanted us to look at the blood utilization, and it's a bit crowded, but when you look at the top panel, we can look at the panel is looking at the center, is looking at outreaches that were carried by the blood collection center, and that they carried around 96 outreaches, a beam, and a bag, and a preprint, what you can. So I think from those, around 4,000, they collected around 4,000 of blood, and from the 6 targeted districts, and observed that Moroto, Abim, and Napak districts had the highest collections in the quarter 3 of the financial year, and so in terms of blood dispersion, to these high-level facilities, you can see that Moroto Regional Referral Hospital received much of this blood, and Matani was the leading, Amudat was the next. But I think here, basically, the things I wanted to highlight is that these units require enough blood, and so we, as the political and the technical wing, need to ensure that we talk to our communities in relation to donating blood. That is basically what I wanted to put across. But on the other end, on my right hand side section there, we can see that there is what we call transmission transmissible infections, that out of the blood that is being collected, they test basically for about four viral and fungal infections, basically, which is hepatitis B, C, syphilis, and HIV. Are being collecting. Hepatitis B, C, and syphilis are the leading contributors to blood infections. And to be for people to change some of their life. So basically here is what I wanted to project here is basically the reasons for blood transfusion, and we can see that iron and obstetrics, including other surgeons, are the leading causes of the reasons for blood transfusions. In the next, please. So here, basically, maternity admissions, and we can see that maternal referrals have increased by 35%. Cesarean section, 32%, and deliveries have improved by 12%. And in the next slide, here basically look at maternal mortality, and here basically we look at the number of mothers, unfortunately, who passed on. And we are expecting that we are supposed to notify, review them, and also be able to provide certificates of cause of death. And so, as a regional referral, we can see that all our maternal mortalities were reviewed and certified. Next. And we wanted here to basically look at these maternal deaths, the MD, and we wanted to know whether it's to understand of these maternal deaths that the hospital registered, referred in or not. And so in the first graph on my left, you can see that 87% of those maternal deaths were referrals in from other districts. And so by level of referral, you can see that general hospitals, health center 4s, health center 3s and 2s, with health center 4s having the highest referrals. Next. And so these are some of the avoidable factors that contributed to the causes of those maternal deaths. With the delay of mothers seeking appropriate health care being at all, and lack of staff, lack of skills or expertise in management of those maternal conditions. And so basically, the factors is delay to seek care, delay to reach the health facilities, and a lack of blood products. That is why in the previous slides, I stressed we looked at the amount of blood that is required and requested for consumption by the different patients. Next. When we did the certification, we realized that for the process of those maternal deaths, we can contribute more to those maternal deaths. 20%, and ruptured uterus and other sepsis following cesarean section at 13%. Next, please. Basically, on my right-hand side, we can see some of the referring districts. What you see in red in those districts that were able to refer to Moroto Regional Referral Hospital. Some of the deaths that had happened, some of the maternal conditions from those districts. Next. And so in the other way, we look at perinatal mortality, basically looking at the last two financial years. And so we can see that the biggest proportion of perinatal mortality is happening around the newborns, with the fresh stillbirths leading and macerated being the least. Next. So by this perinatal death reviews, we can see we went ahead to look at whether these perinatal deaths were referred in. These are basically children. Perinatal means children who are dying below 7 days after delivery. And so, on my left-hand side, first box, first graph there, we went ahead to look at whether these clients were referred, these babies were referred, and so we can see that not all the cases that died, those children that died in Moroto, were referred. But only 25% of them were transfers, were referred in from other facilities. And when it comes to the places of delivery, on my right-hand side, the first graph, we can see that those perinatal deaths were delivered from their health facilities, with only 9% happening in the communities. So in terms of perinatal deaths, that one I think I've already talked about that. Next, please. So we went ahead to do certification of death, and so the causes of those perinatal deaths on my left-hand side, the first graph, is basically looking at the respiratory disease syndrome being the top cause of perinatal deaths, with birth asphyxia at 18% and fetal hypoxia at 16%. So some of the avoidable factors were basically related to those of maternal conditions. And so on the right-hand side, we can see still we are looking at the avoidable factors that contributed to those perinatal deaths. Next, please. Here, as a regional referral, we, through the hub and spoke model implemented by government activities, these are some of the pictures which shows the mandate in relation to maternal services. And the pictures you see basically were the time when we brought in-charges from the different CMOP sites, and we perform and we train them on newborn care and neonatal care. Next, please. Also, as a regional referral hospital, we are mandated to provide medical equipment maintenance. And so in this slide, what you see is basically the team trying to assemble and repair some of the equipment in our facilities. And you can see the availability and the functionality of some of our equipment in the different respective quarters. And you can see the functionality, for example, in the different facilities. By the end of the quarter, our functionality of the equipment was at 86% during April-June 2024. And so even in terms of oxygen production, because the regional referral hospital has a plant which produces this oxygen, and so the facilities usually come to pick these oxygen cylinders. Next, please. These are just some of our works by the regional workshop when they were trying to do oxygen piping at the regional referral hospital issue. Next. So here is some of the trainings that were conducted, the use of the medical equipment in some of our lower level facilities. Next. So the other mandate basically that we are expected is in relation to the regional mandate in medical certification of death, where basically we maternal surveillance in the region. And here, what we call maternal surveillance is basically it's an ongoing and use of all in real time and for dissemination. And so, the regional referral hospital is starting in this event. First, the death that happened at the regional referral hospital certified. And so this certification should happen, should be done by a medical doctor. Next, please. So far, in relation to that mandate of ensuring that are certified, the progress so far is that at there is a mortality surveillance that is composed of Ministry of Health departments, ERA, and so the point is death notification and registration at health facilities. And we are doing weekly together with the national team where we do weekly death summary updates to find basically some of the patients that have been that died and were certified. And so in this, we go ahead to work collaboratively with NERA in death registration and the official issuing of legal cause of death certificates, I mean. And some of the bottlenecks on my left-hand side include the following. And the plans underway is to develop, I think the Ministry of Health is in progress in development of the country mortality strategic plan. And so we want to cascade this certification to the rest of the districts, and where they are going to form death audit committees. Next, please. And so this is basically the uses of some of those mortality surveillance data, where it informs us in detecting, responding, and controlling diseases. Next, please. So, in relation to the third or the fourth mandate, regional referral hospital is mandated to spearhead the HIV drug resistant review and case discussion. And so here you will see that these are some of the patients whom Moroto Regional Referral Hospital, working collaboratively with the districts and implementing partners, were able to review and see the appropriate treatment for them. Next, please. So the other mandate basically that the Regional Referral Hospital has is in relation to HIV, that is drug susceptibility, TB, drug-resistant TB mortality audits. And so here, the activities that we received, the regional referral hospital team from MOH, established an audit committee. Hospital backlog mortalities were reviewed during that period, and all those deaths were notified and registered into the national reporting system. And so some of the challenges were basically that some of those deaths were happening in the communities, which were basically affecting timely release. And also the other one is that we could not do some of the autopsies or due to the non-functionality of our X-ray machine currently. But however, some of the steps that we want to do in relation to that mandate is basically to support the districts or health facilities in establishing those death audit committees. Also providing oversight technical support to the districts in review of those mortalities, and also reviewing them within a week following the death of those cases. Next, please. The other one that we wanted to showcase was basically some of the health implementing partners that we work with. And as a region. And this is the next slide will be showing some of those IPs. Next, please. So these are some of the region. And I think from there, that's the end of my presentation. Thank you.
Thank you, Moroto RRH Hospital. In the course of the discussion coming, we have our senior executive consultant, Dr. Stephen Pandey, is in the house. We have the team from MOH. Still have Dr. Kima. We have the national team around. We had more guests coming, joining us. Ladies and gentlemen, I think I need to hand over also the session chair to the RDC Kotido, who will be taking on the next part of the sessions. But I want to interest us into as the chairs that we know we had a lot of discussions yesterday, and yeah, we had a lot of discussion yesterday on performance. The presentations came when we were a bit hard, but and most of those performances will inform a lot of decisions and actions that will take place in this meeting. And so that's why it is going to be a build-up of the regional hospital performance together with the district performance, and also looking at the league tables. We expect some of those reactions and the discussion. So, we will be first, before we proceed to the other presentations, we expect a few reactions and comments from the stakeholders in the House. And that session of discussion, we wanted to bring it quite nearer such that we don't forget some of those things. The session chair will be led by RRC Kotido, and the discussion will be moderated by the DHO Kotido. And Dr. Char will be taking us through the discussion this morning. And I think the team will guide us through within the time so that we have some good key asks and key discussions out of the two presentations you've taken note of, what the regional referral hospital does, and then also how we have performed as of yesterday. I think your Chair, RDC, please take up your podium as out of this space. And then also I think he will be ushering in your DHO to lead us through this session. Or at least within the span of 30 minutes, we should be having something very good coming up. Thank you so much for RDC. The mic is already there.
Thank you very much. I want to say a very good morning to everybody. I believe that everybody woke up well, and we thank God for that grace. My name is Honoré Ambrose, the sitting chairperson for now, and I want to welcome you to yet a new day. So we proceed, and I would like to invite the DHO for Kotido take up his position, and then come up front, and we see how we proceed. Meanwhile, members, there are a lot of things rotated around the health sector yesterday, but just for the benefit of doubt, I wanted the participants to come to know that the issues of health are more and next issues of security. Once the health sector is broken down, you know that we have insecurity in the whole country. And that's why in most cases, the chairpersons of security, who are the resident distributioners, are very much concerned, and they have an eye on issues of health. Thank you. You're welcome, DHO.
Good morning, ladies and gentlemen. Good morning. I had introduced myself yesterday, but for those who were not here, I'm Dr. Charles. I'm to share the details of the video. And thank you very much for what happened yesterday. We had a good attendance, people were full attentive up to 6:35 p.m. I never had a meeting with my leaders. Let's clap for our leaders. Support, not political. So that's like it has been highlighted. Yesterday we had district performance. Apart from the link table, there are two presentations by Vicky. District performance and then the link table. With the link table, there are two, you tell us why we did very well. Not why. Now you did very well. And then the last two issues were Karanga and what? Academic. So we also need to see how you can be supported. We did this when Kotido did very well in 2021. We had a presentation, a specific presentation, which was, I think it was an icebreaker in the region. We had a presentation and we discussed. That's why now we move to. This is an open floor discussion, but let me open it like this. Do we have, no, director is not there. Okay, let's first start from the district. Nabila took your position number one, but these figures are very small. Vicky, you could tell us, the first column is approved posts. That is in terms of human resource. If you look at the approved post, it's a big with the highest percentage. I don't know where oh, this is it. 80%. That is in terms of human resource. Then the lowest is Kotido. 49, but our figures are 45. So let us first handle that. I think Amadat team. What are the issues and what is the plan? Yeah, with your permission, I'd like to discuss where we taking the discussion, right?
Yeah, they might be before we
So there's Anna there, and Carol, that we need to hear something from you. Because without the resource, we cannot work.
Thank you very much. I'm Dr. Patrick Sagrati, PhD on that. Actually, to be more accurate, our staffing levels around that are not at 40 something, they are 34%. Probably you need to correct that. If we go by the new structure, then we would be at 11%. And initially, one of the causes was a very low wage bill. We could not allow us to recruit more staff, and it persisted for quite long, despite the fact that the district leadership moved on to the ministry to request for more wage bill. Then came in the ban, they added us money, and then at the same time, recruitment ban came into effect. So we could not recruit. So what we could do is to do it on replacement basis, and that is why we stagnated around there. Thank you.
Thank you, members and the moderator. I am the cow that. We have been having challenges in clearance for recruitment. The financial year 2022-23, we returned 1.2 billion in wage for health alone. Last year it was turned back, but there was ban on recruitment. All of us are aware. The Minister of Public Service, together with the Minister of Finance, stopped recruitment because they needed to do the payroll audit. Last Friday, I was in the Minister of Public Service. We are negotiating for clearance. God willing, we shall recruit this financial year. Thank you.
Thank you, Team Amodat. That is from Amodat, and the next poorly performing district in that area is my district, Motilus. My cow is not around. I see 5 have been around, but what? Oh, what is it about? Is it no? Let's first look at it. Yesterday, my SC5 talked comprehensive a lot about, it's just basically about the issue of wage. We get the wage, we shall recruit. Nothing short of that. Ours, we have never received any money which we return back. Though the PS at one time said we return money, that was for the municipality. So it is municipality which have been out the excess wage, not the district. So these are the issues which we raise with all the ministries there. Health, public service, local government, finance. So our prayers is the way we address. Then we shall recruit. Then, Cabo?
Yeah, thank you, Chair. The issue of staffing, I think, is a big issue all over Karamoja. If we are not to consider the new structure, most of our districts will definitely fall below 50%. I'm suggesting we push the Ministry of Health to help the Karamoja region at least every year. They should give us money for recruitment, at least $1 billion. And this will help improve service delivery. I've seen some districts say they have high wage and they have returned. I think maybe the ministry also needs to help us in getting like a blanket clearance from public service, such that when we get clearance to recruit, this is done across the region, like they did one time, and we can even run one advert. So this will help us really recruit our staff. Thank you.
think these issues are cut and forth. Wait, one recruitment. Is there any issue with any particular issue, Karaga? But as the market is moving to Karaga, the ministry has set 80% as the level, am I right? 80%. So any district below 80% will be below the recommended level. Then, in terms of lifting bar, the latest communication was use the lift of land and stop that regional hospital. But not this hospital.
It's lifted.
It is now lifted. So now we don't have money. You get the money? Karen?
Thank you so much. I think when you looked at Kenya in terms of approved costs that I feel standing at 80%, it may not be very true in that the recent concluded interview done, it did attract the most critical personnel to the post. What we have there, like, we have 10 health facilities, and in the 10 accounts that are spread through. And if you went to these health facilities, they are not having all the staff required for the facility. So we are not standing at 80% at the moment. If anything, we should be lying at around 60 or 50. Thank you. Maybe my cow will add on.
So, Dr. Brian, this is pointing to people we might be assessing ourselves with all that. So next time we need to dedicate that presentation. So I think, is there any other thing on human resource? Going forward, what do we do? From the little we need to do staffing gap analysis, which I think we have done, present to our council officers, and then submit by 1st of September to Ministry of Public Service. I think that's the way forward for that. Any other thing beyond that?
But
and microphone.
Ministry for the three ministries should be able to link up to each other. Ministry of Health, Ministry of Public Service, and Ministry of Finance. Ministry of Finance makes a statement about money and says no recruitment. You heard that one very clearly. At the same time, we are having challenges in terms of reaching the 80%. So for us as Karamoja, I think we needed to get a bit of special attention, and the Ministry of Health should be able to support us on this. Because at the end of the day, these indicators will keep repeating themselves. There must be some deliberate effort for this region to be able to recruit, otherwise we are not doing well. And look at the numbers, they are few. In other places, for me, I have been operating a new structure elsewhere. I'm very surprised when I come to Karamoja, we are still talking about the old structure. So what's the difference? And can we compete? In other places, they are operating a new structure, they have extra wage, but when it comes here, there's no money. They are operating an old structure to recruit. Even the numbers cannot suffice the indicators that we're talking about. Thank you.
I think yesterday we talked about selective land in the region. So I don't know the procedure. The PS one time suggested affirmative action for the region. So I don't know the procedure of affirmative action because we actually may not be able to meet set criteria for many things. If it is hospital, may not raise the 500,000. If it is work, we may not raise it, but we need that affirmative action. And we had invited our MPs here, but unfortunately they did not come. Maybe we shall need an engagement with them so that some of these issues are pushed at policy level, policy and manifesto level. So
yes, and maybe before you proceed, when we talk about affirmative action, the officials from the ministry needed to know why. Maybe we just mentioned the word affirmative action, but why? When we have, for example, health education, and then we have our health educators going to the radio, then we look at the rates in this sub-region. We understand that Karamoja needs affirmative action for various reasons. One, because not everybody has got access to radio. So sometimes when we are doing health education, we do not capture the audience that we need to have. And also they need to know that this is a pastoral community, which is highly mobile. In some of these instances, when we talk about ambulances, when we talk about vehicles for the health department, when they give a double cabin, a Hilux to Akiso, they should put into consideration that Karamoja needs a Land Cruiser. And yet in some of these areas, even the Land Cruisers cannot get there. Now, in all this, we need everybody to be on board because we also need a local government to interest itself. Because sometimes I am informed that we fail to attract. Why do we fail to attract? Those are questions. Now, the issue also falls back to the district service commissions. We informed that from the time they enhanced the salary for the scientists, for one to get into the service, they no longer ask for 500 or 1 million shillings. They ask for 3 million, 4 million shillings. And we lock out the people who are more competent because we are waiting for those who have the 5 million shillings. I want us to put our brains together and we discuss some of these issues. If we do not talk about it and we are not open the issues of corruption even during the recruitment exercise, then we will not be able to achieve. Thank you.
yes, so you have seen now the issues moving for human resource. We talk about affirmative action now.
Thank you, Presenter. Well, I'm touched from the cultural side, but we had an experience as the Board of Governors for secondary schools. We had a shortage of teachers in Karamoja, but we were given a special vehicle 2 years ago when there was no recruitment, and Karamoja was given a special vehicle to recruit across the region, and we got teachers on payroll. So I agree with my brother when he says we need to have that avenue. Let's stop generalizing. Let's have that affirmative action. It's possible. Unfortunately, our big political people of parliament are not here. But I don't see difficulty because, as the chair puts it, we can really make a way out with all those reasons behind. We can't reach the population. We can't get the standards. So let's look for a special vehicle to reach that area. Thank you.
Yes. Thank you, moderator. I think certain things need to be done on the first issue first done. My colleague from Nabilatu, who has come from another region, I also came from another region.
It's only in Karamoja where things at times are done last. The issue of structure, it came out in 2021. The health sector structure. District councils should first of all customize this structure. Then it is uploaded on HCM or IPPS. And then you can think of recruitment. So you cannot recruit unless councils are customizing, feedback into Ministry of Public Service. The new structure is uploaded on HCM or IPPS, and then we can now move on to recruitment. That's the only antidote we need to do. So my call is on the these chairpersons and our councils to mobilize and have the new structure, customize it, and that's the first thing first. Then, even if you want to think of affirmative action, yes, it will be offered from a political and policy plane, but have
100%. We had that experience. No, when hospital was upgraded, we moved from municipality to the district. We were not able to pay them from the district because the hospital structure was not in our IPPS. See, I agree with you. So, our chairperson are here. We need to request the chief administrator to have this presented to council, discuss, customize, and back to the human resource team on the customization. So approval by public service and then customization. I think police we have exhaustively discussed of the secretariat, the state. Then the next one is the scholars on the immunization. Thank you very much for moving to this exercise, right? Much better now. DPT is the disease and deafness, the measure of immunization. And then the dropout is when we start the last miserable rubella. DPT we start from DPT 3. The dropout is from 1 to 0. At 1, then how many do we? If we start with 10, we end up at 9 months with 10. That is what the dropout is saying. So, Mr. Edgar said, the ADHD of the MCH, how many years here? And correct me, 95%. Am I right? Huh? 90. So any district below 90, but most counties put at 90. Public Health says the coverage of 95%. So any district below 90 there, you need to know why. But there are only 2 issues here: access and utilization. What are the issues? Which are the district current? You are at 23. ADHO, 12 states. Meanwhile, the IT team can focus, can get us to the map of the region. You come back to this one, the map. Yes.
Okay, for Karana, you find that these children, they may come, they get yes, and they will disappear before completing all the 3 doses for IPT. So, you find out also, we have far that the facilities are not outreach. And what other facilities where those outreaches are hard to reach. And we have one facility that has a hard to reach, and it is very insecure, whereby experts need to be available so that they reach those facilities, those outreaches. And at the same time, transports that could be available would not be there because of bad roads to those areas. My colleague can also add on something, but before that, what we discussed as a team, we say all the areas that we have in facilities, we should advise these attendants to come with the child health cards, whether they are bringing these children for treatment or for any other services at the facility, such that those entry points, they may check at their child health cards, and whatever antigen is due is given. Thank you.
So, thank you very much. Well, Karanga district is doing very well in organization just because we have integrated outreaches which are implemented by every facility, and our immunization at facility level, static immunization at facility level is done daily from Monday to Friday. And at times, some children are immunized on Saturdays. And the district outreaches, which were hard to reach. So the teams are able to reach to those hard to reach places. So that's why you see that improvement. Thank you.
Will give us organization. You also did not do well organization. You know, the president is so passionate about organization. He jokes that he said when they came to power, what God was equipped for the children, but now all these person have no deformity. No, sir, that's what he said. So you play with the immunization, you have passed the honors of something. The President's manifesto. So we are here helping because we are covered.
Okay, thank you, Doctor. Once more, I'm Sister Molly from Nakapri. I'm sorry for the indicators of Nakapri, but all in all, as Nakapri, we are always doing our best. We are always vaccinating. We are always doing to the best, even reaching the hard to reach areas. But what I know, the issue which is failing us in Nakapri, which is putting us to category 3 for a long time, Nakapri is a bit, I can say there is some, Nakapri is a bit special because of the two districts that are attached to Nakapri. Nakapri is in between Nabilatu and Amudat. Remember, Nakapri was a mother district, and Amudat was removed from Nakapri, and Nabilatu was removed from Nakapri. So the population issues is the one which is putting us in problems. First of all, the population of Nakapri, we are always working at a population of 133,000, And yet, during this recent survey, the population came at 112 for Nakapri, which means we were working beyond 21,000, which was bringing us down. Then at the same time, you get that Nakapri is having some of the populated areas that we are supposed to vaccinate that are almost next to other districts than Nakapri. Like in Nabilatu, we have some population which is next to Natira Health Center 3, which is near Nabilatu. Not near Nabilatu, but which is in Nabilatu. Maybe that's why Nabilatu is doing well. I can see doctor is smiling. We have a very big population called Awiyare, and Awiyare is highly populated, but Natira Health Center 3 is just like 2 kilometers. And yet for us, we have to move over 45 kilometers to go to that facility. So for us, we are happy that the population is served, even if we don't get it. And then of course also we have another population that is near Amudan. Actually almost more than 5,000 or what. We have Namolemo, which is just near Achurch or Health Center 2, which is under Amudan. And yet that is the population of Nakapri. Even during the yellow fever campaign, we were almost fighting from there because the population is ours, but it is near Amudan. We met with Amudan team, we had to tell them that this is our population, you can vaccinate the half, we also vaccinate the half. But the population is for Nakapri, but Amudan took over. We cannot quarrel about that. And then, of course, we have also a challenge in the district. We have 3 facilities that are army facilities. We have 407 Brigade, we have Nakapri prisons, we have Namalu prisons. These facilities don't have the staffs that can do work. You get Nakapri prison as only one health worker. Can this health worker deliver? Can this health worker do immunization? So most of the time we get low indicators from those facilities. Though as a government we have supported some of them, but not to the expectation that we are supposed to do. Otherwise, all in all, we are doing our work. If we are not vaccinating, I think there will be an outbreak in Nakapri, but we have not seen an outbreak since. That is why I'm comforted that we are vaccinating, we are doing our work. That is about the bad performance in immunization. But of course, I'm also happy that we did well in quality improvement. And I don't know how the outsider, how a visitor can come and get that things are good in your home. So which means we are doing something. Because this quality improvement is not done by Nakapri, it is done by the outsiders. How comes that they rank as number 1? Thank you.
Because I know that even in Kutino, sometimes the staff pass the other side, they have issues with their bill, they have issues with their form, and usually people, the staff want to fight. What they're struggling for, clients. Thank you. But there is some I think we will need results on that. As well as we are talking about the issue of human resource, we should be advised to how the client this new sensor, the sensor will help us understand ourselves better. Thank you.
Let's also be mindful of time, colleagues.
We have only 5 minutes to go.
The 5 minutes will be mine, I believe. Before I submit, I would like to appreciate what Madam has just explained. One of the serious issues is struggling for people. This was seen during the population census. The same applied to Karamoja. When I was still in Campedo, going to work, I found the people of Karamoja had already taken the census. So in this scenario,
what do we agree in the house? So that right indicators are given to qualify the right information that is predicted. Two, for us in Karamoja, what we are also that I have listened carefully and it's not coming out. The younger mothers fear to visit the health units. The younger mothers fear to visit the health units. And just as my officers are put from there, we also have slightly some few bad roads. That's very true. And then thirdly, these areas that are very difficult to reach. Karamoja is a district that is surrounded by hills. Go to the north, go to the east in Kawalakot, hills. Come to this side of Depot, hills. Go to the other side, hills. So I think it also contributes to a low data capture because it is slightly difficult to climb there. However, generally, somebody has talked about insecurity, but security now is not a big problem. I need this one to be very clear. Security is no longer a big problem. I say all this for God and my country. Thank you.
Okay, please, again.
You wanted to say something?
All right.
I have clarified it with the officer from Nakapiprit because majorly I thought the challenge would be what the RDC was saying. They have Mount Kadam. And you know there is a population that's captured and they need to be reached with services. So, but when they are talking about the boundaries, the people, Moroto is taking, I don't think we've been clashing as much. The Nakapiprit could be having the grass, the Pokot are having the people where the grass is. But then it needs to be streamlined very well. It's not only in Nakapiprit, I think even in Nakonye here. When we're having yellow fever, by the time the health workers went to Nakonye, already Moroto people had served them. But this is service. What is important is let's ensure all Ugandans get the service. It's not about who does the immunization and who gives which service. It's just ensuring that everyone has been reached with the service. Thank you.
Thank you very much. Just to add on a little bit, we learned a lot during yellow fever vaccination. One, we used to have daily review meetings as the DHT. So we were underscoring, asking ourselves why. Many people were saying we're underscoring because Moroto came and the vaccination in Nakonye and Nakapiprit also came inside there. So we said, but we must be having the population. And we were using VHs mostly. But LCs, voluntarily, we are coming to teams and telling them, our people at the other side. So we had to bring LC ones on board. And let me tell you, it was a game changer. The LC ones took us to where the people were, which the VHs couldn't do. So I think it's very, very good to involve political leaders in these services. Thank you so much.
So, let me take on the two. Just only 2 indicators as far as the time. Yes.
Yeah, thank you very much, Chair. For me, I think there is something we are not addressing because at the end of the day, we know Karamoja as a region has a total number of children whom we need to reach. And these children, they are distributed across the 9 districts. Now, if we are saying Kotido is immunizing the children of Kalenga, and then Nakapiprit is saying our children are being immunized by Amudat. But at the end of the day, at the regional level, we are not reaching where we are supposed to be. Then that means there is something we are not addressing. Because if District A was immunizing children for District C, at the end of the day, all the children would be immunized. But that's not what we are seeing at regional level. Thank you.
sister, let me try to, but these are critical issues, by the way, colleagues. Because here, yes, sister.
Okay, thank you so much. To add on what the team has brought out, one of the issues affecting immunization is incentives. Our clients are used to incentives after vaccination, and it is so much affecting the coverage. The other thing is inadequate staffing. When you look at most of the staff we are talking of these percentages, most of these people are support staffs. The critical staff are really missing, and then the other thing is the mobile population we talked about, and then the distance from one facility to another is very distant. And then the issues of poor road network, seasonal rivers really blocks the access of these children. And then the other thing is, we talked of insecurity. We needed not to run away from it. So, other things.
Don't repeat what has been mentioned.
Yes.
Please.
But this is the way we need to see how best we can help these areas. Look at places like Nakonyenasi say. That place is very distant from the next facility, which we need to consider. If it is raising up more health facilities, you need to lobby for that. Otherwise, if we considering the population alone, we may not help these people out there. Thank you.
Colleagues, if you are getting a microphone to repeat, I'm going to stop you.
We should be raising.
Okay.
My chair.
Just a minute. Just because we have a lot of potential issues, I will ask another thing. I want to ask for a minute.
But don't repeat.
That this is the most difficult time. But let us try to precise the point and let's not have
The current recommendation is when we are in a district, let's look at our data and see which sub-counties have major problems. And like zero dose, these are children that are not immunized. Where are they? Because if you don't tackle, we'll be talking in circles. Look at each sub-county, where are they? And what can we do to address? There are those that are not immunized. There are those that got either one immunization or it's not complete. And this applies even at antenatal attendance. When we analyze our data, where do they come from? Secondly, when the regional referral presented on the death, which places do these mothers come from? Yesterday in the presentation, I think I had, there was no death in Nabilatuk. But when you see in the regional presentation, there are mothers who come to die elsewhere, but come from those district. If we did what we call community papillotomes, look at every mother that died in that community, you will realize that when you die in the regional hospital, you're taken back for burial in your home, not elsewhere. So we've done this in other districts, and you'll find there are many deaths. People die in other places. Now, the issue of being across the border near this, but also you also may be poaching on another. That should not be a major problem. But let's also look at leadership issues to streamline some of the challenges that we have. Some of the districts that have challenges don't have a substantive DHO. And some of them stem from there. No authoritative decisions are taken at a certain time, and we leave things flowing in a certain direction. So let's look at other issues other than just only numbers. Thank you.
Kaleka has substantive. Gabon, and then I think, my God. I told you the room is not with me. Who be near the microphone? mention a repetition like this, the microphone is off.
Thank you, Chair. I just want to say that the immunization in Karamoja, we're doing well because as a region we're in category 1. Because somebody previously had said that as a region we're not doing well. So this accounts for children which districts immunize when they are from neighboring districts. So it helps us cover up that. I wanted to mention one of the reasons why we're doing well as a region is because of the partner support. And I want us to recognize our partners. A partner like UNICEF in my district in a year helps me conduct over 300 outreaches. So I need us to clap for UNICEF. WOSA helps us support some outreaches, UHA, and now Malaria Consortium. This really helps us address the issue of access. That's why you see our coverage is above 90%. Then the other important issue, which
thank you, a lot has come out about places that are insecure, and I would like to state it clearly that let's work together, especially when it comes to these operations of immunization. When there are outreaches to those places that are insecure, let us know, and we shall task the DPCs to deploy personnel to the teams that are going on the ground so that those issues don't come up that the places are insecure, that's why we cannot reach to those places. Then to the local leaders, I'm aware in some districts under Chidepo, there are sub-counties that don't have police stations. And we want to request, because there is in those areas that are hotspots, so that we can solve those issues here. The controversy there, you continue to tell us, come without soldiers, then you will work. You see that? Yeah, Dr. James is there. So they tell us come with us soldiers, and they have never stopped. Those days we get them with the guns, but they let us go, do our work, and then. So it is tricky. Maybe other district. For me, I've never used escorts.
Yeah, thank you very much. Very quick one. We have health. In my district, we have well-established health facilities for UPDF, for the police, for the prisons, and they serve a significant proportion of our populations. And even it's not only their services are not only limited to the uniformed personnel. The people actually from out to go there to seek for health services, but they have never received the fridges for vaccines since. We really need to do some. Maybe it's the same thing in a number of other districts, but we need to really encourage UNEP to consider providing these health facilities with refrigerators. They have human resource actually, and they even receive other supplies from national medical stores through the district. But the issue is that they are not getting, they have not got refrigerators. I think we need to do something because there are a lot of people who go there, and it's missed opportunities for most children who go there and they are turned away without vaccination. So we need to do something about this. Thank you.
So, winding up, the issues which has been contentious, which we were raised in organization meetings, struggling for people across border. In the last meeting, we resolved, our dear leader, we resolved that our technical teams should not cross into but the willingness to seek care is upon the person who wants the service. Is it clear? Yes, it's upon the person who wants the service. But if the is here, continuity team should not cross the other side. They can put their service point on the side of what? Continue. Then those from Abib, we see that happening in Samko. Those from Abib, Samko, they want to cross from Samko to come to this side. Yeah, that is the honors is upon them. But it will, ideally, much as we agree here, I see the service of the people of Karamoja, everyone, and so on. One time we hear people are forced and kill each other. Because we have the numbers at one, I cannot accept to see a being coming to vaccinate 2,000 children across the border. Because I also need that number. But if you put it, your service point the other side, and my people go, it's okay. So if you put it this side and people come, it is fine. Let us respect it. That is what we are resolved. It is a big thing, by the way. It is just being discussed here somewhere super, but practically on the ground, it is a big issue. That is what we resolve because of number and percentage. No one wants to be seen in red. To be ashamed before my leaders here, when I know where it is coming. So that is what we have resolved in the last meeting we had. And I encourage the ADHOs to always log in and attend this national meeting. Before I came, I want my leaders and partners to look at this map. These are facility distribution. When these people are saying bad, that is how our facilities are distributed. Like Kotil, you see how concentrated. It is looking small from here, but when it comes to distance, from Kacheri there to the border with the Karega is about 80 kilometers. So, how would you expect health worker from Kacheri to walk that distance? Is it possible? It's not possible. You walk the whole day and then after not doing anything. So, we reach our people through outreaches. At these outreaches, we need to transport health workers. The Ministry of Health gave us vehicles. We have garbage cars, COVID cars, and the PS has been communicating to district leaders to say we share. But let's share these resources, not compromising what? Service delivery. Other leaders, they said this car will not move away. And how would you expect us to reach there? So we need transport. When we give you our programs for our service delivery, release even more vehicles. This is something which can be done. And the PS has communicated about this. Just simply that. Then rest funds and how to reach and so on. Then the issue of allowances. I have not had any instance where mother will ask for allowance to vaccinate a child, maybe in other districts. I have not. What else? Human resource, we talked about it. So, colleagues are how and why we are not performing well. Partners, UHA, from support outreaches. That is the only way we can serve our people. Then the technical team will do the rest. Let's get back to the presentation. It is coming to break tea time. I want to pick on one or two indicators only, and then the victims. The Excel was better.
Excel.
Vitamins, let's go to perinatal death. So MPDSR. Perinatal death and maternal death. Maternal death, we have no issues. The policy, the guideline says when a mother dies due to childbirth, the death must be notified within 24 hours and reviewed. When I say reviewed, the technical team. That is sitting to find out what caused the death of the mother. It is not, it is not to blame the facility, not to blame the staff. So, for maternal death, we have done well, but still we have issues with perinatal death. These are national, these indicators here are the national indicators which we assess to. So, we have a maternal death and maternal perinatal death review committee chaired by the RDCs. So the RDCs in the house need to take note of this. These committees need to be tasked to function. You see the column for, if you are moved again, perinatal death review. A baby has died around birth up to 28 days. Is it 21 week? 28 days? The ADH of 28 days, right? Yeah. Is there anything which is difficult for you to go and sit and review what has caused the death of these mothers? So let me hear from Nakapiripirit. Is there any problem? We had you very well, what are issues and so on for immunization? But this one, the baby has died. And you are aware of it. That is laxity. Total laxity. Yes, Nakapiripirit.
Okay, thank you, Doctor. About the perinatal death, normally we try our best because the perinatal death is supposed to be notified within 24 hours and it's supposed to be reviewed within 1 week. But the health facilities do try their best, only that sometimes if there is any issue, it can be issues of data, but they do try and we support them, and I support them as ADHO always with reviews. And I remember we had an issue with the perinatal death where some of the perinatal deaths were not reviewed, which we did it for the district. If there is any issue, it should be a data issue. But we handled all the issues of the perinatal death. We didn't have any issue. Even according to the quarterly review meeting we had 2 weeks ago, We had reviewed all the perinatal deaths.
So, how do we, now if it is the issue of data, you have to advise that. There's usually quarterly data cleaning where the system is open and any data error, what should have been corrected? That ADHO website. Now, if you sit and you expect data to be corrected, you will not. Good barristers have honest.
Okay, Esther Chen is my name, ADHO Amuda. Concerning perinatal health notification,
not notification,
review, we are at 609, just because there are some deaths that are not done in hospital yet. There is a backlog that I'm going to follow up. Actually, I've been reminding them because they were to do it because we came up with the action point that they do every Wednesday. So I am going to follow up on that, but at least the review of maternal death, we have been doing it at 100%. Yeah, thank you.
Data does not lie. Why do you want to contradict your data? Can you go back to your
another thing also.
You cannot say 100% when we are seeing here what?
Maternal death.
You want me to call Dr. Mugai here and face him?
Okay, another reason also, our biostat told us that sometimes when you upload the data, it remains on the system, it doesn't reflect. So this is why I will go back to follow up again.
The RDC are listening, they are the chair of this committee. You know, I always ask my team, when you talk about data not synchronizing to Cotido only when other districts are. What is it only Cotido? So, for leaders in the house, when the death occurs, it is notified. And those percentages are calculated from the one you have been informed the ministry that death has occurred. So why do you inform that 10 deaths has occurred and you only review 6? That is why you don't achieve 100%. Then there is a problem, and it is a total laxity. Dr. Mugai says this cannot be tolerated. And we should repeat that it should not be tolerated. Why do we need to underperform in an indicator where we have 100% control? Are we too busy to do our mandate? Even the same to continue. The issue of data. But for maternal death, it's okay. What about the children? Are they too many to be reviewed? Are we too busy to review the death of children? Think about it. Let the chair who is the RDC talk about this first.
Yes, first and foremost, let me thank the chairperson before physically present with us. And you have heard how they have come out very strongly to support the health sector. Now, when we have information that you invited the members of parliament and they have not come, and this is not the first time, the other time again they did not come, most of this. How are you expecting? And I don't want people to get angry because I'm going to use words that the greatest percentage of people in this room, that word should not offend you, are foreigners. Did you hear that? Now, if we have 75 or 80% of foreigners discussing issues of your home, is the home still yours? Is the home still yours? Because these people, almost all of them have come here, they are going away tomorrow. But the owners of the home are not there. So next time, we really want to know, because if we told the members of the parliament, they are going to say that they never ever received the invitation at all. We want proof next time that you really invited them, let them acknowledge receipt of the invitations so that we can be able to task them. When we have issues that we are talking about wage, and the issues of wage are more discussed in Kampala when they're in parliament. And then we're having the LC5s here raising their voices, which are only going to remain in the walls of this home. What are we expecting? These issues are pertinent issues, and I think that this conversation of today should be able to open our eyes and make us. When we have, it's also good that the issues of boundaries and struggling for clients has come out clear, because the commanders of the people who fight are here. The DHOs, you are all here, and you are the people who will tell your staff that this is where you are going to operate. So now, if a health worker beats another health worker, who is the responsible person? And I will disagree when they say that, you see, some of our DHOs are acting capacity, that's why they are not performing. But if you look at the record, I think the distributors performed very well. The DHO is in the acting capacity, or I'm wrong. Now, when you're in acting capacity, you work so hard so that you are confirmed. And that's why sometimes it's better to have almost all of them in acting capacity, so that they work continuously. Am I wrong? Those are things. When I'm acting at DC, I should be able to perform very well. And when I'm there at DC, I should work hard to become the Minister of State. Those are issues. Now, the issue of Karamoja, ladies and gentlemen, at first I want to commend everybody, because everybody has tried his best or her best. I want to commend everybody in this room, because I see how they work. You know, this is an area whereby almost everybody does not come to work or stay with a spouse. You know how psychologically it counts as a pastor. Are you aware? You come here, your husband is somewhere else. And every time it starts raining, you are wondering what will happen this evening when it's very cold. Yeah? These are facts that people don't want to talk about. But they are facts. And yet you have to wake up very early in the morning. Now, my problem also goes backwards, that some people who come from within and have got gardens, instead of going to work, they first go into the garden. Am I wrong? So who performs best? How do we evaluate someone's performance? When he starts with the garden, then the other one, because his garden is 170 kilometers away, he will go to the office and start working. These are issues. These are issues. And definitely, there is no reason why, by the way, it is criminal for you to go and operate in an area which does not belong to you. Are we aware? That's when the raiders go to steal animals and they say they have crossed the border by 1 kilometer, that UPDF cannot follow protocol. Also, it is not right for you to go into another district running for clients from another district. It is criminal, by the way. Why don't you operate within your district? What's your problem? And yet, at the end of it all, we have not vaccinated all the children. Even when you run very far and you live in your own district, unvaccinated children. Now, the next issue, I want to thank you. It is time for the health break. We're going to come back. I want to ask someone to bless our health break, and then we can revert back to this room, and then we discuss more. I saw a hand, okay, but I was of the opinion that some people may not have been able, they came in a rush, they did not have no breakfast, would allow people to go for the health break, and then we come back. Can I have a volunteer to bless our food?
Yes, sir. The chairman has instructed. After I want to say there's certain critical thing.
Gracious God, let's have ourselves. Thank you, God. Let's bless. We ask you to bless this food that you have set for us and make it medicine for our bodies. In Jesus' name we pray.
So I share the rescue to me. But I was going to pray. Okay, thank you.
I'm going to get some. That's what I've done. That's another. Just be removed. Yeah. You're live, no?
Yeah, that's
What about you?
see you later.
See, these are being shared. What do you think? See? I think your thing has just been slow. It has just been slow. I'm sorry.
What's the thing about slow?
Now, there, I have to go and now. Sharing this thing is like gambling. No, it's done.
But you see,
So I share the second screen. Now, then that second screen. What I've been doing. When I was no, what things were showing? I'm telling you that. But you see, the thing is, once you, what I'm doing,
I was like, I looked at your screen.
it's like,
I don't know. You're like, I don't know.
yes. How is that? Yes, I'm sure like 6.